Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, he's back from France with stories to tell. It's my co-host, Frank Gaylard.
Hello, Dixon. It's been a very long time. I have made it back from France in one piece, no injuries, and much cheese was eaten. Did you have a good break?
I did, yeah. I had a very, very good break, actually, but I'm kind of looking forward to getting back to work now so I can relax. My wife likes to pack a lot of activities into our summer holidays. But going back to your holiday, though, I'm tempted to do a bit of a Dale Kerrigan. He's the character from The Castle, which is a classic Australian movie, and ask you nothing at all about France, but instead to say, did they show you any films on the plane?
They did. I can give you my opinions of the movies if you'd like. Although, I'm never sure how valid any opinion of a movie that you've seen at half atmospheric pressure while jet lagged and drunk is.
And drunk, yeah.
Let me think. The standout was Civil War. I thought that was excellent. Really liked it.
Not the Marvel one. That's a different one, isn't it?
No, this is a US Civil War when a president refuses to step down from office or something. It's left pretty unclear as to which side's which, etc.
Yeah.
But that's sort of the premise, and it's sort of a road trip movie with an older journalist and a younger journalist who she's mentoring. But the performances are excellent. Like, really enjoyed it. 4.5 stars from Frank's rating out of 5.
I actually do remember hearing a podcast earlier in the year or earlier in 2024 about that one and meant to watch it. So I'll definitely put that on my list. We've actually done Oscar predictions in the past years, Gaylard, on the podcast just for a bit of fun. So I wonder if any of the ones you saw on the plane were Oscar nominated. We could do kill two birds with one stone in this episode.
I'm not sure if any of them. I mean, I'm not sure if that one was. If it's the right year. It should
I'm
be.
looking up Civil War now, and it was not
really?
nominated for an Academy Award, but it was nominated for a 2024 Golden Trailer Award. How bad is the human attention span now that we have to give awards just for trailers rather than the whole movie?
Oh my God, that's awful. Maybe they'll have Oscars for the best react to YouTube video.
Yeah. Best social media meme of the year.
Oh my God. Anyway, at the very other end of the spectrum of goodness was Mission Impossible Dead Reckoning, the part 1 or whatever, the one where Tom does the motorcycle jump. And it is so long, so boring, so pointless. And it's only half a movie anyway. And it's one of those movies that is just entirely based on a MacGuffin, a thing that you need to find that is pointless, except for the fact that that's what drives the story.
It's a plot device.
Yeah, and so it's vaguely AI, and there's this MacGuffin key thing, and in one place it's in Istanbul, and then it's on a train, and the other thing that really annoys me, which it annoyed me that it annoys me, but I'm watching this action movie, and all the lead actors are kind of old.
Yeah.
And it's like, I don't want to see old people with plastic surgery doing bad stunts because their joints hurt and they have to rub Tiger Balm on it. I want to see people that are believable. And as much as, I have, respect is probably the wrong word for Tom. No, I have respect for his stunts, but I'd be more interested in seeing someone new. This just feels like accountants filling in a spreadsheet and making
ticking
money.
Boxes.
It was just, and now there's another half, and I really can't be bothered. I don't even think I finished it. I kind of just
it's interesting that they called this one part 1, but then they've dropped that for the second one because they're like, people didn't really see the first one, and we don't want to call this part 2 and make people think that they have to see part 1 and they haven't seen it. So speaking of rubbing Tiger Balms into joints, though, I've actually been pulling up Saw lately each morning because I've been playing a lot of this VR cricket game on MetaQuest 3 that I got for Christmas. I say I got from Christmas. Actually, my daughter got it for Christmas, but she hasn't used it. I've used it entirely. So I've been, facing fast bowlers at 145 kilometers an hour, in swingers, out
Yeah,
swingers, Gaylord. You probably don't know what any of this
I
means.
do not, but that's okay.
And I've got this 3D printed cricket bat that you attach the controller to. So it's not just a controller you're swinging around. It's actually like this 3D printed bat. It
Yep.
feels very much like a real cricket bat, proper handle.
How many
But
things have you
it's
broken in the house? Lampshades,
I've hit a
hit
couple
the
of things, but
dog.
it's short, so it's not the full length of a bat,
Right.
but it feels like it in your hand. And then when you put the 3D goggles on,
Yep.
it looks like a real bat that you're
Oh, okay.
wielding, right? And the graphics aren't amazing because it's obviously got to process it all visually immediately on your head, but the physics are unbelievable. Like it feels like this ball is genuinely coming towards you. It's bouncing, it's moving off the
Hmm.
pitch, and the same shots that I play in real life that I'm good at, I'm also good at in the game. The same shots that I'm terrible at in real life, I'm terrible at in the game. And if you go, right, I'm going to try and just lob this one up on the onside, it does exactly what you kind of are intending to do.
Yeah.
Like it knows exactly what that bat and that ball would do in the real world. It's
These
fantastic.
simulations are getting amazing. The one sport I kind of follow is Formula One. They have very strict rules about how much practice they can have, which is
Mm,
basically zero. And so all the drivers, most of the drivers anyway, spend most of the time practicing in simulators. A full professional kind of rig that Red Bull or something has
yeah,
matches the car so precisely that these guys spend hours and
yeah.
hours memorizing.
Well, I've seen clips of professional cricket players who've never played this cricket VR cricket game before,
Yeah.
putting on the goggles and playing it, and they can play brilliantly
Yeah.
straight away. Like it actually transfers the skills from real life into the
Yeah.
game, and hopefully from the game back into real life. Although I never planned to face an actual cricket ball coming at me at 145 kilometers an hour, because sometimes you're standing there, the ball comes in, and before you know it, it has passed through your head. Like
Yeah.
it just go, and you just see this thing go through your head, and you're like, "Ooh, that would have been real bad
I
in
don't know
real
if I
life."
told this story before, but I have a friend who used to play cricket at uni for the uni cricket team in
Mm,
the A's. So he was a decent uni level player. And one day, an Australian medium bowler
mm,
came to play with the team. And he faced three balls from this, not a fast bowler, just a medium bowler. And he
yeah,
said he never saw them. They just went past and he
yeah,
swung, and one of them he hit it by mistake, another one he completely missed, and the third one took out his stumps.
yeah.
Um,
I face a few of these deliveries, and the first few that come down, you have no idea.
yeah.
And then it's amazing how you do get your eye in, and you start to work out how fast they're bowling and what you can do in that time. It's called IB Cricket.
Yeah.
And so, if anyone's listening and has a sponsorship for us, I'd be very interested. This is the one sponsorship that I want.
Yes. And welcome everyone to this new podcast reviewing computer games and sport.
Have you got any more movies that you saw on the plane?
Oh, I'm sure I'm missing a bunch because I watched a
Some
lot.
quick
But
fire reviews.
okay, the Wild Robot was,
Oh
which is
yes.
an animated kids movie. It's actually very funny. There's some laugh out loud parent
Okay.
sarcastic moments. Easily 3.5. Alien Romulus, boring, dumb, didn't finish it. 2.5 stars, and which is a real shame because I'm a big fan of the original
Yeah.
Alien movie.
Yeah.
Furiosa, boring, didn't finish. Started watching a TV show called The Regime with Kate Winslet, which is
Haven't heard.
about a Middle Eastern, Eastern European country where she's the prime minister and
Oh.
gets in corruption. It was too cerebral for the plane. So I'm
Yeah.
going to revisit it at some point, but it was pretty funny. I think that's enough. I can't remember anything else, but I'm sure there were many, many more. There's no way you can fill 48 hours of travel time without
Is that
seeing a
what it
lot of
was?
TV. It's about 24 each way. Yeah,
Oh gosh.
I know.
Yeah, that's a lot of movies. Well, we need a little jingle for Frank's movie reviews or something to play before and after. But we should get to today's main segment, Gaylard, and it could not be more up your alley, actually.
Hmm.
This is a neuroradiology update recorded at last year's Radiopedia virtual conference. So this panel was hosted by Francis Deng. He's a neuroradiologist at Johns Hopkins, and he was joined by Tabby Kennedy, a neuroradiologist and associate professor in the Department of Radiology at the University of Wisconsin-Madison, and Tom Campion, a neuroradiologist at Barts Health NHS Trust in London, England. Now, for context, this was recorded just after Tabby had delivered a lecture on idiopathic intracranial hypertension and Tom a lecture on non-MS inflammatory and demyelinating CNS conditions. So I'll hand over to Francis now, and then Frank and I will be back for another chat in the outro.
I'm joined now by Tabby Kennedy from Wisconsin and Tom Campion from the UK. Welcome both.
Thank you so much, Francis.
Thanks, Francis. Great to be here.
Why don't we start talking about the neuroinflammatory lecture? I thought it was a great overview of some of the non-multiple sclerosis type of diseases that are uncommonly seen on a day-to-day basis, but are nevertheless important for radiologists to recognize. I find that neuroinflammation is a really difficult area within neuroradiology practice. Part of that is the kind of non-specificity of some of the imaging findings. And part of it, as you alluded to, Tom, was kind of the drawn out follow-up for some of these cases. I wonder if you have any advice for junior radiologists starting out and who are trying to become experts in this area. How do I approach developing my experience with this and following up on the cases that I call and seeing what happens?
That's a really good question. And I think it is a difficult area, especially for people who are coming through who aren't necessarily doing neuro all the time. I think kind of slightly perversely, I talked about non-MS demyelinating conditions. The best way is probably to get really, really good at MS imaging, because what you really need to be able to do is see all the potential ways that MS can present. By doing that, you can begin to understand what the red flags are that should pull you away from it and pull you to something else. Because so many of these cases will end up being MS, even if they are presenting in an atypical fashion. But what you really want to be able to do is kind of spot the things that should just make you say, okay, this looks a little bit odd. Do I need to suggest an extra test here? Do we need to think about taking CSF? A lot of these people are going to have those kind of paraclinical tests, obviously, anyway. But you want to be able to get to the point where you can suggest that something is likely to be inflammatory demyelinating, and then throw those extra differential diagnoses in there. And really, I think the way to do that is to go to if you've got a neuroinflammatory MDT, make sure you go there, see the hundreds of cases of MS, and then see the ones that don't quite fit, pull those together, and see what kind of connects those. I think that's probably how I would advise my kind of registrars to go about it.
Yeah, I think probably the exchanges at multidisciplinary conference are very useful for this kind of less common entity, just to give more exposure. Do you have something like that at Wisconsin, Tabby?
I don't know that we have a specific multidisciplinary conference that talks about, inflammatory conditions or MS, but we do have a monthly conference that we will look at kind of interesting cases kind of across the board. So it's not specific to neuroinflammatory or demyelinating diseases, but generally, we're always available in the reading room to have a conversation about it. Tom, I've got a quick question for you about the workup. Do you end up suggesting a second test, say beyond CSF analysis, looking for aquaporin 4 or MOG antibody only after a negative workup has been kind of already done with MS? Or at what point does that workup happen? I'm kind of just curious about workup in the UK versus the US in terms of that process.
Yeah, I think increasingly we're basically beginning to send antibodies off for most people. I don't know if that's the same for you guys as well, but I think in some cases where they're very, very typical findings and the brain imaging features are very characteristic, then you might just make the diagnosis. But in general, I think when there is a kind of acute demyelinating episode, a lot of them will get antibodies straight off the bat, particularly if if there are any kind of atypical features. If you've got kind of simultaneous bilateral optic neuritis, if it's kind of more posterior, if it's involving the chiasm, if you're not really seeing as many brain features and seeing more long segment. If there's anything that's even slightly off, they'll go for antibodies pretty early on. And it's getting quicker and quicker to get them back. I imagine it's probably slower for us than it is for you, but we are getting a quicker turnaround on those tests now. So whereas it used to be they'd have to go off to a reference lab and it would take a few weeks to come back and you'd sort of be twiddling your thumbs in the meantime, now they're coming back within days. And So it's just much more accessible.
Yeah, I find that the neurologists are usually testing for MS, MOG, and MO with any optic neuritis episode. So in that setting, what is the importance of us trying to distinguish between the three, radiologically, you think, Tom?
Yeah, I mean, it's a really good question. We've got to question our worth every now and then. I think in particular, the kind of distinction is not completely antibody based yet. It might be in the near future, but particularly with the NMO diagnostic criteria, you can have antibody negative NMO, and there's a kind of demonstrable difference. If you treat someone who's got NMO as an MS, you're potentially going to not improve their condition. So that distinction is quite important, and it may not be an entirely kind of antibody-mediated decision. So I think that from that point of view, it's still important for us to have that in mind, and try and have an idea of what the kind of imaging features are that we've talked about in the lecture. The other thing I think is, particularly for neuroradiologists, you're quite often going to be the people who start picking up these phenotypes early on. So it's worth having that kind of baseline of what you're expecting, because there are going to be people who don't present as a kind of classic demyelinating syndrome, particularly if we're seeing with some of the MOG cases that have presented quite differently to NMO or MS. And you just need to be able to say, oh, actually, I have seen this as a presentation. Maybe we should think about MOG in this case. I think the flip side of that is that we can start saying, well, it can cause anything, so we should just test for it everywhere. And I think that's a bit of a dangerous road to go down. But I think it's good for us to kind of build up our library of what we think these cases look like, and those can develop into diagnostic criteria down the line.
That brings me to my next question. MOG antibody disease wasn't a thing probably 15 years ago. And probably over the course of our careers, there will be new diseases that are discovered and diagnosed, and they'll have some fancy acronym. And I certainly, in the course of watching your talk, Tom, learned about new diseases I hadn't heard of before, like the subtypes of MOG antibody disease called flames and fuel. And there's a whole another alphabet soup of all these autoimmune encephalitides that just couldn't fit in your talk. GFAP, GAD65, NMDA receptor encephalitis, and so on. Clippers, slippers, and dozens of variants like that. To what extent do you think it's important for radiologists and neuroradiologists in particular to keep up with all these new developments of diseases and subtypes of diseases that are newly discovered, and try to learn their imaging phenotypes?
I mean, I think it, particularly for neuroradiologists, I think it is important because we're going to be the ones who are potentially suggesting these things. I think I find the autoimmune encephalitides really difficult because loads of them are going to have normal scan finding. So it's where you can add value by picking out kind of particular imaging patterns. And the only way you're going to do that is by looking back through all of the cases that you've got with a particular antibody and seeing how it works, taking that to conferences, picking up how other people are reporting it. And that's how those diseases are going to emerge. And I think there is a tendency for us to sort of sit back and say, well, we'll let the clinician sort it out. But actually, imaging is absolutely crucial for kind of the majority of these diseases. And we have to build up that phenotype ourselves. So I think it's incumbent on us to really stay ahead of those things.
I want to pull on something that you mentioned in your talk. There's always a thought in the back of your mind that something could be lymphoma, right? What do you think is the usual kind of diagnostic pathway for patient presenting with some brain disorder? It's initially thought to be inflammatory, and then they ultimately wind up with a diagnosis of lymphoma. Give us an idea of how the diagnostic pathway progresses.
Yeah, I mean, I'd be really interested to hear Tabby's opinion on this as well. But I think we've seen a few cases where you've got someone who presents with something which has some kind of patchy enhancement, has some white matter signal abnormality, a little bit expansile, and responds extremely well to steroids. They get a bit better, but then they have another episode, and perhaps it's a bit worse this time. The CSF is a bit indeterminate. And I think those are the kind of cases where there's a crossover between, we think, oh, maybe this is demyelinating or inflammatory because it improves when we give them anti-inflammatories, but it could also be a vasculitis and it could be a lymphoma. And I think the real difficulty with those cases is knowing when it is the appropriate time to pull the trigger on a biopsy, because there's a slight feeling that it's a bit of a failure to get a biopsy result of demyelination. I don't know if you guys feel this as well, but when we used to have some of our pathology conferences, there was a real kind of gotcha whenever the pathologists came out and were like, well, this is demyelination. So I think everyone's sort of trying to avoid that, because also you feel like you should be able to make that diagnosis on imaging. So I think it's really, I mean, as all these things are, it's about a kind of a multidisciplinary approach. And once you've raised the idea of lymphoma, it's very difficult to get rid of it completely without getting some tissue. So if you're not seeing improvement, that's what you end up doing. But I'd be interested to hear how it's different across the pond.
Yeah, I agree, Tom. I mean, I feel like in those situations where you've got, that kind of exact scenario that you outlined, I can think of a handful of cases, over the last, couple of years where I do have a biopsy proven, demyelinating disease. But then on the flip side, we also have a number of biopsy-proven lymphoma cases, right? And so I think that what's really helpful about that is obviously that conversation has to happen with the neurosurgeon, but then also with the neurology team to help target where is the best place for biopsy. Because ultimately, you need to have something that is firm so that people can feel confident with the treatment strategy. And I think, on both sides, with lymphoma or otherwise, having that tissue diagnosis can be helpful. Now, oftentimes it's not going to be the first thing that, people are going to go for. It's going to be after a serial, number of exams, you're going to try steroids, et cetera. And it's really going to be as that final, decision point is generally how it happens with us. Francis, how does it happen at Hopkins?
Yeah, I think it's a long diagnostic journey for many of these patients. I think it's helpful if you're reading the initial imaging study at the outset to offer a broad differential that people can kind of keep in the back of their mind as they go through each of the steps of workup. First, they'll have a lumbar puncture, CSF sampling, test for all the things. Then they might get empiric therapy with suppressants, with steroids, and re-image in a little bit to see if they get better or not. And if it's persistent on follow-up, then you might consider the next more invasive step, which would be biopsy. But sometimes, people's diseases progress at different speeds, and this pathway may take a circuitous route before achieving the final diagnosis. So I wanted to transition into our topic on Tabby's talk on idiopathic intracranial hypertension, starting with where it kind of overlaps with Tom's talk and talking about people who have optic neuritis, because these can often present with visual loss, and on exam they have optic disc edema, and they get sent for imaging because they're working up optic disc edema. So my first question for you, Tabby, is is there a difference between optic disc edema and papilledema, and how do the ophthalmologists use these terms?
Yeah, I use them differently. I don't think that they're really synonymous terms. I think that papilledema really implies that there's optic disc edema related to increased intracranial pressure, and that could be idiopathic, or it could be related to something underlying, say like a tumor or sinus thrombosis, for example. But optic disc edema is really just in that physical exam finding plus, you can see that on imaging, but that doesn't necessarily imply that it's related to increased pressure. So if you take that example of a patient that's got optic neuritis that has bulging of the optic disc, because that optic neuritis goes all the way to that optic nerve head, they do have optic disc edema, but it's not related to increased intracranial pressure. And that's really that distinction between papilledema and optic disc edema.
Mm-hmm. So optic disc edema can be due to various optic nerve pathologies as well as increased intracranial pressure, which would be papilledema.
Yeah. And so like if somebody had, say, a meningioma of the optic nerve sheath, maybe that initial, presentation could be that they've got optic disc edema, but then after some time that optic nerve actually atrophies or gets smaller. And so you can even kind of see that change in the caliber of the optic nerve, but that is not really related to increased intracranial pressure. It's really localized pressure at the level of the optic nerve itself.
I enjoyed reading your paper on use of post-contrast 3D FLAIR and identifying papilledema in patients with idiopathic intracranial hypertension. we don't actually get post-contrast 3D FLAIR with our orbit protocol, but on occasion we do see optic nerve head enhancement on patients who have papilledema on fundoscopic exam. And I was wondering to you, how specific is this imaging finding for the fundoscopic finding of optic disc edema, and is it particular to one cause or not?
So I'll say that when we did that paper, it kind of came out of one of these scenarios that I'm sure that you both probably have encountered, where as you read scans, you start to pick up on a couple findings, and then you see that there's a trend, and so then you're like, okay, well, I want to study this and see, is this just me, or does it actually kind of hold out in a way that you're assessing a number of patients that have these findings. And so what that allowed us to do was to really review the literature related to those findings that happen at the level of the optic nerve head. And what we've seen is that you can have enhancement of the optic nerve head in isolation. And so they'll refer to that as papillitis. And that optic nerve head enhancement, it's kind of the same, phenomenon that you might expect to see in the setting of blood-brain barrier breakdown. And so you essentially have just that breakdown at the level of the optic nerve head that you'll see with IIH. And so we find that 3D FLAIR contrast enhanced scan can be really helpful, because that's a study, or that's a sequence that we actually include pretty much in most of our protocols. So even if somebody doesn't get a dedicated cranial nerve or orbit MR, we're going to capture that finding. I used one example where it was somebody who came in, in their 20s, came in with a headache and neck pain, and they thought it was a dissection. And we, our stroke protocol had multiple sequences, and the only finding actually could be appreciated on that 3D FLAIR sequence. And so I find that 3D FLAIR sequence to be particularly useful. It really highlights enhancement plus the T2 signal property, so it's almost synergistic, and it allows us to really see that optic nerve head edema. So we'll see it in the setting of IIH, and then also in the setting of other reasons why you might have optic disc edema, like optic neuritis.
Tom, do you do anything special like that for your Orbit's MR protocols?
No, I mean, some of the protocols that you were showing, like your stroke deluxe protocol, I was incredibly envious. I mean, we get about 3 sequences for our stroke protocol.
Oh man, I'm kind of jealous of you.
I was wondering though, with your when you're doing the post contrast FLAIR for these for the orbits, do you think you pick up, because people talk about these other kind of like leptomeningeal findings in MS and stuff, do you end up seeing other findings that you wouldn't necessarily pick up as a result of doing that sequence?
Yeah, I think it's really helpful for leptomeningeal disease, I'll say. So kind of moving back to your inflammatory discussion, that 3D FLAIR is a very sensitive sequence. And so if somebody's got leptomeningeal enhancement, that's going to be the sequence that we're going to find it on. We end up including the 3D FLAIR even on our just orbit only protocol. It's a way for us to make sure that we're just capturing anything in the brain that would help us kind of narrow our differential for those optic nerve findings. So we probably capture a little too much, but I think it's helpful for us to allow us to kind of narrow in on the differential.
I think that's a really good idea, because the idea is that, if you see optic nerve head enhancement, it's not necessarily an implication of optic nerve inflammation. As you said, it's blood-brain barrier breakdown that can be due to anything. It could be due to high intracranial pressure. It can be due to ischemia potentially, or it could be due to some inflammation somewhere. And so if you see a classic periventricular white matter lesion that looks like a Dawson's finger MS lesion, then that dramatically increases the probability that this patient has MS, right? And so too, I guess, with the other kind of white matter diseases that Tom mentioned in his talk.
Yeah, that's exactly right. So as opposed to, bringing the patient back for a whole nother exam, we can kind of capture most of the findings just with that one sequence. And so we find that to be particularly useful.
If we don't have access to MR, I find it's really difficult to call anything about the optic nerve itself, or even to the optic nerve sheath or the optic nerve head. Many of these patients who have IIH come through the ED and the go-to modality is CT, but I find it's really difficult to teach how often should we raise the possibility of IIH on CT, because some of the findings are subtle and maybe not quite as obvious as they are in MR. Tabby, I was hoping you could give us some advice about what findings on CT should we be looking out for? When should we be raising that suspicion of IIH?
I would say, it kind of comes down to the clinical history that hopefully should inform how one should interpret those imaging findings. And so if you've got, a young female patient in their 30s who's coming in with a headache, pulsatile tinnitus, and visual symptoms, and they start off with a head CT because that's kind of just reflexive of what oftentimes the ED providers are it's just going to be the quickest exam to be able to get. And so I would say if you see a partially empty cella or only in that context, could you then suggest, well, the patient really needs to get an MRI? They probably should have gotten an MRI at the beginning, but I feel like it's really that having that high index of suspicion that you should be worried about IIH. I had a very similar patient, a couple weeks ago where they got a CT angiogram of the head and neck. And so if you actually have contrast, that then at least gives you some window to look for transverse sinus stenosis. So at least if you have contrast, even if it's a CT in the angiographic phase, you can still get a good look at the veins. I would say, look specifically for venous sinus stenosis. If you have venous sinus stenosis plus a partially empty cella in a patient that's coming in with those symptoms, that's when you could potentially suggest it. You might also see, prominent arachnoid granulations or pits along the floor of the, middle cranial fossa that might be markers of increased pressure. So those are findings that you might maybe even be able to see better on CT than on MRI.
What do you think, Tom?
Yeah, I mean, I think we get a lot of, we've got an eye hospital near us who send their kind of acute patients to us. So we get a lot of young women who have CT head and CTV. We quite often get into that situation where someone's saying, well, are these optic nerves tortuous? Are they dilated? And obviously the answer is to get an MRI. But yeah, for all of the things that Tabby said are the kind of things that we look for. So yes, it just pushes us a bit further if they've got a partially empty cella and they've got the stenosis and the arachnoid pits. But I think it is difficult because once you've said that to someone who's not necessarily seen a huge amount of neuroimaging, they start seeing it everywhere. And obviously there are going to be a lot of elderly people who have partially empty cellas and they suddenly all end up with MRIs for IIH. So we've got to be really cautious about how we use this information.
That's exactly right, Tom. It's like, okay, in the demographic and in the clinical presentation, you can't now start to use the partially empty cella in all comers and say, okay, that then equals IIH. It's really the elderly individuals that have a partially empty cella. Yeah, that's probably just a partially empty cella. It shouldn't carry the same kind of next step clinical implication in terms of getting an MRI. I don't know, Francis, what do you think?
I totally agree with you guys. The clinical correlation is everything, and we should do everything in our power to limit our kind of overcalls and suggestions of this diagnosis to the population that's most relevant. And I mean, we can see on the image if they're overweight or not, or we can glance at the chart to see if they have an elevated BMI, which would be a significant risk factor for IIH. But we should, when we have access to the chart, take a look at their symptoms. Does it include headache? Do they have tinnitus? Do they have cranial nerve 6 palsy? These are all the things that should raise flags in our mind as kind of neuroimagers and neurospecialists to think about whether IIH might fit with a given clinical presentation.
I was just going to say, I'm interested in the pulsatile tinnitus side because I think we are beginning to see more patients who we have our kind of pulsatile tinnitus protocol for who we're ending up diagnosing with IIH. And I don't know if that's just something that has been around for ages and we're just coming around to it, or whether it's sort of increasingly being picked up in that context because we're investigating it with more imaging. Be interested to know what you think.
I feel like anecdotally, IIH is probably the most common cause of pulsatile tinnitus in the patients that are referred for imaging. And that's why we have a protocol for pulsatile tinnitus that includes not only a CT arteriogram, but also a CT venogram and a high resolution temporal bone CT to look for dehiscences, in the sigmoid plate that might, transmit the reverberations of turbulence in the venous sinus downstream of that venous sinus stenosis. How about you guys, Tabby?
We have a pulsatile tinnitus protocol that's more MR based. Now, I'll say that kind of depends on how the patient's coming in. If they're coming in from a specialist or from the ED, I'd say if they're coming in from the ED, they're going to probably do a CTA because it's just easier and faster turnaround in terms of not having to get kind of screened before the MR. But if they're coming from ENT or from neurology, I'd say that they're probably more often going to be coming in and getting an MRI. And with MR, we have some time-resolved angiographic images that we're both looking at the arterial side and the venous side to look for, dural AV fistula, but then also transverse sinus stenosis. And so we're kind of trying to tease out both of those potential avenues or causes of pulsatile tinnitus.
Yeah, my anecdotal impression is that there's not much standardization across institutions about a pulsatile tinnitus imaging protocol. The idea is you need some arterial imaging, venous imaging, and some kind of temporal bone imaging at some point, whether to do that with a mix of CT and MR or start with CT and then go to MR, kind of as an institutional preference. Thank you once again, Tom and Tabby, for joining me for this chat.
Thanks, Francis.
Thank you so much, Francis.
Thank you to Francis, Tabby, and Tom for that discussion there. And if you're a Radipedia All Access Pass holder, then of course you can find Tom's lecture on non-MS inflammatory and demyelinating conditions and Tabby's lecture on idiopathic intracranial hypertension in the Radiopedia lecture collection over on the website. Frank, anything to bring up from that discussion?
Well, the first thing I want to say, and this is me using this podcast as a confessional, is that when I listen to Francis, Tabby, and Tom talk, I feel like a complete imposter because I find white matter disease so hard. When you drift outside of routine MS or chronic small vessel ischemic change, I start to break out in a sweat and issue vague, hand-wavy reports. I mean, it's not that I can't describe what the findings of other conditions like NMO, spectrum disorder, or MOGAD, etc., should be. But when it comes to actually applying them to any individual scan, I actually find it really difficult. And I suspect so do the clinicians, and thus the rise of molecular markers. It's like, oh, this person, it's not obvious that they've got MS, so let's just check that they don't have any of these other things. And I think we have a very low threshold now, at least at my hospital, to obtain CSF, and probably all of patients, even those with classic MS, get them anyway. And I think that's probably a general trend in medicine more generally. There are so many conditions being described that are so specific from a metabolic or molecular point of view, but that have overlapping imaging and clinical features that it's all getting a bit hard, especially as the diagnostic criteria are increasingly molecularly based. And so when we hear about these conditions, I do wonder about what the role of imaging over the coming decades will be, to be honest, and how much really we need to suggest specifics, or we just say white matter bad and clinicians go off and do a whole bunch of stuff because they don't know either, and then the lab just tells them what it is.
Yeah, I wrote down exactly the same thought as I listened to this panel discussion, Gaylord. I was like, neuroradiology is fun when I can look at the scan and I can come up with a confident diagnosis that the clinicians weren't necessarily expecting. It's like, oh, Andrew, well done. You came up with this. It isn't fun when I have to say, oh, it could be this or it could be that or it could be nothing. Or more likely it's, something I haven't even heard of.
Yes.
And then sometimes it's like, oh, I didn't even think about tumor. It was lymphoma. What?
A whole category that I got messed up on.
Exactly.
No.
I just thought it was inflammatory. Oh gosh.
It shouldn't be so hard. The other thing that I liked was the explicit distinction between optic disc edema versus papilledema. I think that's something I'm definitely going to pay attention to. I do think I make that distinction, but I'm not sure I do it as carefully as I probably should. And the other thing I wanted to bring up in the discussion that is interesting is about incidental findings. We've probably touched on this before because this is a massive issue in radiology.
It's a Gaylord goat, for sure.
It is a Gaylord goat. But like an empty pituitary fossa or a prominent arterial loop in the internal acoustic meatus, there's this balance between dismissing these versus drawing unnecessary attention to them. because in so doing, you kind of do generate unnecessary anxiety and follow-up tests and expense and misery for the patients who have to take a day off from work, or maybe their siblings need to bring them in. And so much of this depends on knowing the referrer and the patient's clinical history. And I wonder if in a not too distant future, when you dictate, as you're reporting something, partially empty cellar, that an AI that has digested the whole patient EMR will say, hey, did you know this patient has been getting unexplained headaches? And that would be really helpful, right?
Yeah.
Because it'd be like, oh, maybe we should be making a bigger deal of this.
Mm.
Or this has no bearing on anything we know about them. Probably should bury it in the report if I even mention it.
I suspect if it looked through the EMR, every patient would have headaches
Yes,
somewhere written
that's
down.
true.
Do you always say partially empty cellar, or do you sometimes just say empty cellar? I know this is slightly off track from what we were just talking about.
I almost always say partially empty cellar. And I only mention it when I don't think it's normal for age. And then depending on the context, I'll either add something like a common incidental finding in asymptomatic individuals, or maybe something like of dubious clinical relevance, but should be correlated with a history or findings of intracranial hypertension if I think it might be relevant.
Yeah.
But I must admit that I often feel dirty bringing it up because I don't think I'm usually doing anyone any good.
But I also find it annoying because the official term is empty cellar, but it isn't truly empty. So we all have to skirt around that by kind of saying partially empty.
Yeah.
You know what I mean? Like it just feels,
Yeah.
I'm more of a cellar's half full kind of guy anyway, gay lads. Anyway, getting back to AI, I suspect you only threw that AI comment in there because you were subconsciously wanting to talk about DeepSeek, which is the thing that's blown up in the news and the stock market over the last week. Have you been using it?
Yes, I have actually. Guilty as charged. For those of you who are not keeping up with every new chatbot that comes out, DeepSeek is a new chat GPT-like large language model. It's marginally outperforms existing models, including ChatGPT 4.0 and Claude 3.5 and other similar top-end LLMs. But it has done this with a fraction of the hardware and only cost apparently $6 million to train, which is orders of magnitude less than the other ones. And this is a big deal, I think, because at least from one perspective, the AI safety argument has been largely today, hey, everyone, relax. There's no rush. We can take our time. We can slow down and do it safely because no one outside of the USA is anywhere near these big open AI projects. And when they say that, they usually mean China, right?
Yeah, China.
China. They're years behind, so don't rush. We can take our time. And that obviously is not true, at least for this level of performance. And it probably means that there's now an additional incentive for all involved parties to rush ahead and remove more safety concerns and cut more corners to see if they can get to whatever the next plateau of AI intelligence is. And I think, this definitely increases the chances of it ending very badly. I don't know how high those chances are. But the other thing that's interesting is in this case, the very unsubtle censorship and political pro-China bias. Depending on what you ask, you either get a sort of saccharine pro-China response, or it categorically refuses to answer, or sometimes it'll give you what feels like a more balanced answer and you see it being typed as it goes. And then at some point, the whole thing gets redacted and it tells you, that it doesn't. But I've been reading some posts of people finding workarounds. So for example, it won't tell you anything about Tiananmen Square when you ask it directly. But if you ask it in Morse code, it will reply in Morse code and give you the whole thing.
That's very funny.
And one of our developers was talking and said that these large language models may or are sort of the new frontier of state or political party propaganda. In the 80s, we had Murdoch's newspapers, and in the last 20 years, we've had Fox News, which are, have their definite slant and bias. And now, depending on which large language model you use, you're going to get a distorted view that's aligned with whoever's paying the bills, I guess.
Yeah. I guess if it is indeed that cheap and quick to make a high-performing large language model like this, like there's no special source that OpenAI had, if others can do it relatively quickly and cheaply, then at least that should mean that there should be more choice available in the future, more competition, more models available. Positive thing I'm taking away from this, though, if there is a positive, is that it's a potential win for energy consumption, right? They didn't need as many chips or as intensive hardware to do this. And there was so much money the last few years being pumped into bringing power plants back online or building new ones just to provide energy for data centers around the world. And if it's true that you can do this with a lot less computing power, it could be a massive win for the environment. So that's what I'm kind of holding on to at this stage.
Yeah, and it's bad news for NVIDIA that had $600 billion taken off its market cap, which is crazy, right? Because everyone thinks, oh, well, you won't need as many chips. But the thing that's really crazy is that 600 billion didn't make much of a dip in its chart if you look at the stock price. It's like, it's just a little bit.
I am annoyed about NVIDIA because when we were doing AI stuff probably, 6 or 7 years ago, the initial stuff we were doing, and the guy I was working with was like, oh, there's only one type of GPU we can use for this. It's this NVIDIA chip. And I was like, okay, whatever. I should have gone, hang on.
I know.
AI can only be done with one type of chip made by one company. Let me invest.
I know.
But I didn't.
Whenever I read stories about time travel, one of the things is always, well, how can you monetize this? And, stock market is the clear thing. All you need to do is pick a couple of stocks per decade, and then it's like, oh, that's it. And sports betting is the other
You'd only
one.
need one, and then you're set for life, right?
A few Bitcoins.
Yeah, exactly. Bitcoin.
These are definitely interesting and scary times. Anyway, if anyone out there needs a bit of existential threat reading that will keep you up at night, I can strongly recommend any of the essays by Nick Bostrom. Link in the show notes. He's great, smart, hard to argue against, not super cheery.
Okay. Maybe we need that's what you need for like a chatbot. You need the Nick Bostrom chatbot that you ask a question that he argues back at you.
Yes, everyone trains their own personal chatbot.
Yeah. Based on all the blog posts I've ever written, this is how Frank Gaillard would respond to this situation.
Well, I saw a thing of Facebook or Meta coming up with personalized Instagram avatars that were basically personalized chatbots that were meant to answer. And it was such another Facebook PR disaster that it lasted a week before they suddenly backtracked. Because, of course, people immediately did the internet thing and tried to have the most inappropriate conversations with celebrities possible and then posting them everywhere.
I think it might be time to wrap this episode up. Gaillard, how can people get in contact with us?
Well, you can email us at podcast@radiopedia.org with any ideas and or feedback. And you can also join the Radiopedia community chat by visiting radiopedia.org/community.
Yes, we love getting your feedback. From our recent environmental sustainability episode, Gaillard, someone in the YouTube comments wrote, this is great, what is this woke BS? What on earth does radiology have to do with environmental sustainability? Just talk about radiology, FFS. Not diversity, ecology, women's issues, or any other insane neoliberal garbage.
Do you think that's a bot?
We must be doing good things when we get a comment like that.
Oh, yeah. Keep the anti-woke comments coming, folks. I'm sure it drives engagement. It's all good. Actually, as an aside, after a memorable dinner with the in-laws very recently, which I'll bore you personally the next time we catch up for lunch because I can't realistically do it justice here. I came up with a T-shirt logo that we could put on our non-existent merch shop, which is, I'm not woke. Some of my best friends are racist.
And if you want to support, on that note, and if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle-income countries. Conference program has been released. The R poster, abstracts, submissions are open. So, it's all happening, Gaillard.
It is.
And what else can people do to help us out, Frank?
And you can also help out by leaving a 5-star review in the podcast app of your choosing. Not our choosing, your choosing. Whatever it is that you like to use.
And also word of mouth. Tell your friends about the podcast. Every little comment helps. And I think I'm going to actually play some audio from the castle. See, did they show any films on the plane in the outro? Because, I think our non-Australian listeners may enjoy it. Or otherwise be totally confused by it.
Or both.
Yes. So I'll whack that in here, and we'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Stay rad.
Stay rad.
We had a choice between fish and beef Wellington.
Beef Wellington?
What's that, Dale?
It's beef done in pastry.
And it was an absolute credit to the airline.
Did they show a film?
2.
2?
Yeah. And they also had these 8 music... Twister. We saw Twister. Oh, and they had these 8 music...
Was it on a screen or a telly?
Telly. And they had easy listening, classic gold, contemporary rock.
What was the other one? The other film?
Jumanji,
yeah. And with the
which one was first?
Twister. You could turn the sound.
How many on the way back?
Dale, you can ask all this later.
Sorry, Joe.
It was so dry in the plane that your hair actually dehydrates, doesn't it, Con?
Yeah, it loses its moisture. So interesting.